Vascular Diseases Awareness Day, and to discuss vascular and endovascular surgical data, we have with us three experienced and eminent doctors from Manipal Hospital. We have with us Dr. Venkatesh Reddy, who's a senior consultant, vascular and endovascular surgery. We have Dr. Aziz Pasha, who's a consultant for vascular and endovascular surgery. We also have with us Dr. Hemant Kumar Pandharpurkar, who's also a consultant, vascular and endovascular surgery. Welcome, all of you, to BW Healthcare World.
Thank you.
My first question to you, doctors, and any one of you can choose to go ahead and answer this question. What is considered as vascular disease and what are its symptoms? So would you like to go? Yes, Dr. Venkatesh.
Yeah, good afternoon. Vascular disease is a disease of any blood vessel in the body. We is a separate entity. We take care of vascular surgeon, except heart and brain inside the brain. Any vessels in the body, there is called any occlusion of any arteries and veins. That's called vascular surgery. We take care of that one.
So, what are the symptoms that a person should be careful of that, you realize that these are the signs when you should be consulting your doctor?
See, we can divide in three parts. One is there's this called ischemic stroke. That is any stroke to the brain. Any blood vessel to the neck vessel is a blockage or as a clot goes. That's called stroke. That is the ischemic brain stroke. That is involved in the carotid vessels. Or in the lower legs extremities, any blockage of blood vessels in the legs or aorta thing, major vessels. So blockage causes leg ischemic leg attacks. That's a typical how we call heart attack. This is called leg attacks. Other is the same similar thing in the for both upper limbs. So these are broadly we can classify these three.
But Dr. Aziz, are there any feeling before this attack happens that can kind of give you a sense that you are heading for this problem?
Yeah, see, like Dr. Reddy told, see, one is the leg attack. Leg attack, usually these patients who are diabetic, patients with other comorbidities, when usually they'll have some kind of a signal. Like when patient walks for a distance, he gets pain. Like a patient who's a smoker, commonly you see claudication in these patients. So what happens is, for some distance he walks, he gets a typical pain in the calf. That means the calf is signaling him the not enough blood is reaching there. So these are the signals. This kind of signals, when you get, the patient should immediately report to the hospital. See, when a patient comes with claudication, we can always treat him conservatively with medications. Patients who ignore and they continue, later they come with the blocks continue and they come with gangrene of the toes and then discoloration of the toes and they come with ulcerations. This is for the arterial system. One is like a leg attack. Similarly, like Dr. Reddy told, for a brain attack, patient will have some symptoms like suddenly patient gets some episodes of what we call as a transient ischemic attack. Suddenly patient doesn't remember for a minute and he comes back. So typically they come to the hospital saying, sir, this kind of a thing happened to me. This is when you do, some patients even come with some, he comes and tells like, suddenly there was blurring of vision. I couldn't see through one eye. So this kind of patient, you do a carotid Doppler and you see that you'll find out there'll be any blocks and if the blocks are not major, then again you can treat them with medications. If if it is more than 70%, then you treat them with surgery or by stenting. So this comes to the arterial disease which we're talking about. When it comes to the venous diseases, hello?
Yes, sir.
Yeah. When it comes to the venous disease is not that bad as like an arterial disease. Patient won't have that much of a problem, but still he continues to suffer, So patients, especially patients who are people who are standing for long hours, like our health professionals, like policemen, like barbers, these people who stand for long hours, they tend to develop varicose veins. So whenever they see any dilated engorged veins in the legs, if they come in early stages, where there are different grades of varicose veins. If they come in the early stages, again, we can treat them with stockings. Usually patients come late. This kind of awareness, if they have, as minimal veins are seen, immediately come do the Dopplers and see whether do a Doppler test and see whether the junctions are okay. Such patients can be just treated conservatively with compression stockings.
Got it.
So once the patient ignores, they continue, then the patient will come with swelling of the legs, with discoloration, with pigmentation, and finally some patients even come with ulcerations. So these are the symptoms you need to look for.
Right. Dr. Hemant, what, do people with diabetes or certain kind of similar lifestyle diseases are more prone to these problems?
Yes, there are certain risk factors for development of these vascular disorders. With regards to the arterial system, that is the blood vessels which supply blood to different parts of the body, these arteries commonly get affected in patients with long-standing diabetes, hypertension, dyslipidemias, and who are smokers. These arteries tend to get damaged and get narrowed over a period of time, and over a period of time, they get completely blocked. So these are the patients who are more likely to get these arterial disorders, arterial occlusive disease. Some smokers also get dilatation of the larger blood vessels, which we call aneurysms, because of certain degenerative changes in its wall because of smoking. So these arterial disorders are particularly common in patients with diabetes and hypertension, dyslipidemia, things like that. Yes. Whereas venous disorders, as Dr. Aziz Pasha said, certain hereditary factors, certain lifestyle factors like long-standing and things like that can lead to development of these varicose veins, and that's a different entity in itself. Yes, but yes, diabetes and hypertensive patients are more prone to arterial disease.
Dr. Venkatesh, let me come to you, and this is specific for varicose veins. What are varicose veins and what causes them?
See, varicose veins are nothing as Dr. Aziz has told. Is there long, tortuous, dilated veins in the legs? Is a bulges, you can see that one. Those are this one. Patients are risk factors for varicose veins. Usually aging, you have with a family history. Then some people have a prolonged standing. Then the smoking, sedentary lifestyle. Most of it runs in the family, as I said, and hereditary conditions. And usually for females is during pregnancy time do tend to develop these things.
Like you said, women seem to be, is it more prevalent in women specifically?
Yeah, especially more prevalent in women because during pregnancy, they do tend to develop this because of increased intra-abdominal pressure. So most of the time after the delivery, usually these veins reduces, and for some people patients it still remains. Even they remain, most of the time they are asymptomatic. That means there's no symptoms, nothing. Some females they tend to develop these symptoms. For them only do a treatment. That's it.
So, but if it is asymptomatic and people do not even come to know about it, is it dangerous?
See, the varicose veins are most of the time we consider symptomatic, asymptomatic. Young females, asymptomatic is not a dangerous something. It's asymptomatic. Okay, we leave it alone. Just monitor, do a compression stocking, just keep monitor that one. Only symptomatic treatment patients only we do the treatment that one.
Okay, and what are the different surgical and minimally invasive treatments available specifically for varicose veins?
See, varicose veins, the treatment options are various there now. But good old standard is a open surgery. Yes, still we do that one, but it's very rare, limited to very few conditions where minimally invasive procedures are not done. Why? Because of the vein, tortuous vein, big veins, diameter is very big. So where the laser, so minimally invasive procedure, we have a big list of things. That's called the thermal treatment or non-thermal ablation. Thermal treatment is a laser and a radio frequency ablation, where these are minimally invasive procedure. In these procedures, we will puncture the vein, and the guide vein just will go on, just block the damaged vein. Is ablate means is something blocking. Is a laser and radio frequency both are thermal, the energy thing. Whereas non-thermal new devices have come. That's called Venous seal. It's a glue technique. It's the latest in technology thing. Then one more thing is come is a mechanical chemical ablation. Both are non-thermal. There's one more is just recently is added thing is called steam ablation. Still we are not used in India. I mean, just going to market shortly now. I think week or so. So the RDA has been approved by DGC. So these are the options available for the varicose vein treatment. And then we same time we do the what do you call the foam sclerotherapy. That is for the selected ways under ultrasound guide. Just go and inject the injection foam to the incompetent perforators so that the blood won't be flowing those veins.
Dr. Reddy, since this particular disease is quite prevalent now, could you share some precautions that people should be taking so that they don't end up having this problem?
See, as I said, this is most just need to control the risk factors. Risk factors, what is the varicose veins is common to the people who stand for long hours. So we'll always advise them to, instead of standing for long hours, keep walking. Or if it's people having this runs in the family, we'll advise them to just get a periodic checkup from the vascular surgeons. That's very important. Then if you require prophylactically put a compression stockings, which prevents the aggression of the or progress of the disease. So always we need to follow. I always suggest follow with the vascular surgeon, not only surgical. We know how to diagnose. What are the options available for these things? So that is a thing.
Dr. Aziz Pasha, let me come to you. My focus while asking you questions will be more on the AV malformations. Can you please tell us about AV malformations and what are its signs and early symptoms?
See, vascular malformations are the most common congenital abnormalities which you are seen in the infants and children. It's because of this localized defects in the vascular morphogenes, and it's caused by dysfunction in the embryogenesis and the vasculogenesis. See, commonly this clinical features patient usually presents with a classical swelling, which is compressible, and you can see with a classical thrill with the bruit on that.
Okay.
This is the classical, and some patients who come a little late, they can come with hemorrhage, that is bleeding. They can come with ulcer, with a swelling, with ulceration there. Normally, these are the clinical features they present with.
Also, where in our body could AV malformations do the most damage?
See, vascular malformations close to the airway, like the air pipe, vascular malformations involving the ears, involving the eyes. These are the very risky places to handle with. The other places, you can always, embolize and go and resect it. In these areas, resection will be not possible. Only endovascular, you can manage it.
And is this condition treatable?
It is treatable. See, majority of the vascular malformations are treatable. If the patient comes early, first we get a Doppler. We'll know exactly. If it's just a superficial one, you can just go sclerose it, or you can go and excise it. And if you think if they do a Doppler, if you see it's extending, you could go for a more invasive test like an MRI with a contrast or a CT and a contrast. Then what you can do is once you localize, then you do an angiogram and go to the vessel which is supplying this malformation. And then what you do is you go and embolize that vessel which is feeding. So once you embolize the vessel which is feeding, then the whatever tumor it shrinks off. Then you can go and resect it out. This is the proper treatment. Yeah.
Got it. And is it possible that this particular disease is being carried on genetically?
No, see, this is a congenital disorder but there's no proof that it is carried genetically. Like varicose veins, it runs in families. It runs among sisters. Okay, if the mom has, your son can get it. This is not the case. There's no proof in vascular malformations.
And then do we actually know what causes the AV malformations?
No, like I told you, it's because it's a defect in the morphogenes.
Great. Can I request you to explain the defect of malforgenes in a manner that it can be explained to a layman?
1 minute only. See, it's because of the localized defect in the vascular morphogenes, and it's a dysfunction in the embryogenesis and the vasculogenesis.
Let me come to you, Dr. Hemant Kumar Kandakar. I'm going to be talking to you more about hemodialysis access. Am I pronouncing it correct?
Almost.
Almost. What would be the correct pronunciation of?
We would call it hemodialysis because
Hemodialysis.
blood. Yeah.
Okay. So, can you explain what is hemodialysis access, and how should one choose the access that is best for them?
Right. Hemodialysis access literally means accessing the patient's body at a site where we can draw blood adequately for enabling dialysis. So for the dialysis machine to function, the function of the dialysis machine is to filter the blood of all its impurities, and it is done in patients whose kidneys are not functioning any further, or at least temporarily or permanently. So we need to filter the patient's blood of all the impurities. For that, we need blood to come out of the patient's body at a fairly fast rate of flow. Flow velocity should be good. So to create that access, we have got various methods. We've got this temporary procedures like putting in large bore tubes into the veins of the patient's neck or in the groin. That is for patients who come at the last minute and who are already in the stage of fluid overload or electrolyte imbalance and need immediate dialysis. So these are immediate methods or temporary methods because that's a foreign body introduced into the venous system. Once, am I audible? Hello?
We can hear you, sir.
Yeah, sorry. Yeah. That is about temporary access. It is called temporary hemodialysis access catheter. It is put into large veins of the patient's neck or the groin, and patient gets dialyzed. But these tend to get blocked, tend to get infected, and these temporary catheters are usually suitable for only a few weeks of dialysis at the most. A more permanent, longer-lasting, suitable, minimally expensive procedure would be to create an arteriovenous fistula, wherein we join the patient's vein to an adjacent artery. Usually it is done in the upper limbs. The artery supplies blood at a fast rate to different parts of the body, whereas the venous return is usually very slow. Directly cannulating the small veins in the hand will not get adequate flow rates for dialysis to happen. To make the blood flow faster through the veins, we join the veins directly to the side of the arteries. So the blood flow goes at a fast rate through these veins. And in about a few weeks' time, the wall is also thick and strong enough that it can withstand repeated needle cannulation to enable dialysis. So this is what is called an arteriovenous fistula. It is usually done in the upper limbs at the wrist, elbow regions. And once done, worldwide, there's only a 80% success rate. 20% fail, they don't mature or they get blocked. So these need to be done fairly well early in the patient's, once a diagnosis of kidney disease is done, it should be done early enough so that there is time to mature and patient is ready for dialysis with a fistula, functioning fistula. This is the simplest one. Then we've got AV grafts, we've got other permanent catheters and various other hemodialysis access methods. Yes.
So Dr. Hemant, how should one care for their access?
Well, access is a very broad term. Temporary catheters in the neck or permanent catheters, they'll have the foreign body introduced in the neck veins and there'll be something coming out. So they commonly get infected at the sites of entry of these catheters. So these patients should always ensure that these catheters are kept covered, especially at the entry points. The dressing do not get wet. that they handled in a very sterile way during dialysis. Commonest cause for infections is probably making the dressings wet at the site of these access procedures. Whereas an arteriovenous fistula, there is nothing inserted. There is no foreign body inserted into the patient. It's a surgical procedure where we join the vein to the artery and close it. And once the vein is mature, each time we put in a needle, dialyze and take out the needle. So there's hardly any risk of infection there. That is the safest. All they need to ensure is that there's no pressure directly on the fistula for a long time. There's no hypotension during dialysis, because low blood flow states can cause the fistula to get clotted off. Once it gets clotted, it becomes a procedure to again open them up. So these are standard procedures, and they need to keep exercising. They need to keep feeling that a thrill, a vibration is felt at the site of the fistulas. And if they're feeling it, that means the fistula is working well. If they develop any pain, swelling, an absence of the thrill at the fistula site, that means something is wrong, and they need to consult the nephrologist or the vascular surgeon immediately. It is their lifeline, these hemodialysis patients. It is a lifeline.
My next question is actually open to all. Any one of you can choose to give me this answer. That are these conditions of varicose veins or AV malformations on an increasing trend? Do we find more and more people having these problems today than in the past?
I think it's
definitely.
Yes. It's a unanimous yes.
Yeah, definitely. Why I say, because there's a more awareness, there's a more population. So these are things called, people are more aware about their health care. So especially the varicose veins and all. So now the number is increasing, definitely.
So you feel it is more because people are becoming aware, so they are getting them checked, and which is why more of these problems are getting detected. Is that correct?
Yes, yes, yes.
Also, lifestyle changes are leading to more such disorders.
Sorry, Dr. Pandharkar, you're not clear. Can you repeat what you were saying?
I was just mentioning also certain lifestyle changes in the newer generation is leading to reduced exercises and being more prone to venous disorders, especially varicose veins, arterial disorders, occlusive disease, etc.
Now, it's a very specifically varicose veins. Does it lead to sexual disorders as well?
See, varicose, that is called a totally different entity. This is not called a sexual disorder. This is called, especially we call varicose vein. That is the varicose vein is the scrotal veins. Those veins, yes, definitely they cause a dysfunction, especially infertile. So that is the where this one we do an intervention for the varicose veins. Yes, that is a disorder is there, and which is a curable.
And cure is typically a surgery.
Yeah, there is a surgical intervention, and a similar thing is endovascular. Both options are there.
Got it. Also, do you feel that the cost of treatment for these surgeries is on a downward trend, or do you think that the cost is actually increasing in the last few years?
See, the cost increasing depends on the very technology what we use. See, especially when we come to the newer technology, the minimally invasive procedures. There's a laser or radiofrequency ablation. Very established, the cost is much cheaper compared to the non-thermal one. Non-thermal is that Venous and Mocha, because those devices all cost a bit expensive devices. Definitely, when using radiofrequency or laser ablation, yes, cost has come down tremendously now.
Dr. Pasha, I mean, I want to ask you, since Dr. Reddy just mentioned about the devices, etc., has the technology advanced to a point that these procedures are easier to carry out? They are lesser implications or lower cost. What do you see the technology development happening in this particular space?
So, see, for straightforward vascular malformations, see, there are different type of malformations. There are venous malformations, there are lymphatic malformations, there are arteriovenous malformations. The lymphatic malformations and the venous malformations, they are slow malformations. So these can be the procedure. It wouldn't cost much because you can go and just resect it and come out. When it comes to the arteriovenous malformation, they are a little complicated. So what happens? There's a shunting between the artery and the vein. So now usually this will have a big feeder coming from the artery. So that artery has to be identified. So for that, you go do an angiogram, selectively cannulate that blood vessel, and depending on the size of the vessel, it comes. Whether it can just go put a glue, is that enough? Or sometimes you need to coil it to block it. And if the vessel is big, then the amount of coils what we use, and sometimes there are multiple feeders. So you may require a lot of coils. So the costing all depends on the size of the malformation.
So, and this procedure is usually covered under insurance.
Yeah, it is covered under insurance. Yeah.
So my last question to the panel is that actually is second last. My first question is that how do you know that this particular procedure requires a surgery versus getting treated by medicine? What is it that a lame person should be aware of, that when is a surgery required? Whoever wants to go in for this, sir.
When it
It's a
comes
rather,
to
okay. It's a rather very broad question. It's difficult to say when exactly the surgical procedure would be required or medical treatment is good enough. That decision, that is what defines medicine, that it's an art. You get all the science together, and then the clinician puts in the clinical picture into perspective and then decides what is most suitable for a given patient. So what the patient should be aware of is the symptoms and when to consult an appropriate doctor. Whether surgery is required or medicinal treatment is the best is decided by the doctor based on the patient's presentations, his clinical assessment, and the patient profile. So it's a very broad question. I would briefly put it that way. I think that's what the others would agree with also. I think.
Anyone else who wants to has a perspective on this?
See, as a surgery is not a first option for most of the treatment, especially when it comes to the varicose veins early stage. Surgery is always a first line of treatment for this one. Is always medical management. Medical management is what we ask them to change their lifestyle, tell the people not to stand for long hours, keep walking. Then put a compression stocking, and there are some medications have come. We'll try for those patients. Yes, if these are not benefited, or if the patient symptoms are really bad, like severe pain or itching or any bleeding from the varicose veins or any ulceration or pigmentation, for those veins only surgery is recommended.
And my last question.
Similarly for AV malformations, if the patient comes early when the malformation is small, just one injection of a sclerosant would do. That will go and block all the blood vessels there. So when the patient comes late, when it's already spread, that's when you intervene for surgery.
Got it. So my last question to the panel is that what are the things that you would recommend to a patient, that these are the things that you need to keep in mind before choosing where to go and get the treatment?
See, most of the time, I put it this way: when the patients have some problem, we'll always advise them to just go to the specialist. I mean, a particular specialist or the department. Or if you don't, just go to a general practitioner. Usually, most of the general practitioners nowadays are advising who is the better person to take care of these problems. So that is a one thing keynote. And most of the people, anyway, if they comes to us, they'll always Google things. They go through the Google internet, they search things, they'll come.
Got it. I really feel that it's a great thing that the awareness levels are going up, so that more and more people are aware of the possible symptoms that they could be having, to identify and get themselves detected really fast. Because as I understand is that if you were to identify this problem at the early stage, it can be treated by medication and you could avoid a surgery. At the same time, what I also understand from the panel is that there are technology advancements that are happening. The surgery is becoming better and cheaper so that, there is more accessible and affordable. And I think Manipal Hospitals has got the best talent, available with them, which is evident from the panel, esteemed panel that is here. I really want to thank you all for taking our time to be with Business World Healthcare. I know you are all busy people, you have heavy OPDs, etc., but still taking our time for the benefit of our viewers. I really appreciate that, and thank you from the bottom of my heart. Thank you so much, Dr. Pasha,
Thank you.
Dr. Pandarpur, and Dr. Reddy.
Thank
Thank
you
you
very
so
much.
much for joining
Thank
us.
you.
Thank
Thank you.
Thank you.
Thank you.